From the JAMA Network, this is JAMA Surgery Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Surgery.
Hello, and welcome to JAMA Surgery Author Interviews. I am your host, Dr. Jamie Coleman. Today, we will be discussing a very hot topic, the use of GLP-1 agonists in bariatric surgery patients. Now, specifically, we will be talking with the authors of the paper, Use of Glucagon-Like Peptide-1 Agonists Among Individuals Undergoing Bariatric Surgery in the United States, a retrospective cohort study. The authors joining us today are Dr. Caleb Alexander and Dr. Mehta from Johns Hopkins Bloomberg School of Public Health. Welcome to the podcast.
Thanks for having us.
Thank you.
Well, we're just going to jump right into it. Now, as your paper stated, bariatric surgery has been found to be the most effective long-term treatment for obesity, and the usage of GLP-1s is on the rise. So to start, can you please share with our listeners some background regarding GLP-1s and patients who have undergone bariatric or weight loss surgery, and also tell us a little bit about what inspired you to do this research?
So we have been working on several research projects related to GLP-1 medications, and we are closely following development in this area. And as we continue to read about this area and continue to keep up with the latest news, we noticed a number of discussions and personal stories going around on social media where people were discussing that once they undergo bariatric surgery and after surgery, when they regain weight or they don't lose as much weight as they would like to, what are their options? And people were increasingly talking about GLP-1 in their personal stories. And this gave us an idea. And when we looked into the literature, we didn't really find a good scientific evidence around this area. So this inspired us to study this topic.
Yeah, I think those are great points, Hemo, and I completely agree. I mean, it's important to keep in mind that although bariatric surgery is the most effective management strategy for the long-term treatment of obesity, many people achieve suboptimal weight loss after surgery or actually have weight regain. And so there's enormous interest in GLP-1s for just about everything these days. And we thought it was really important to take the opportunity that we had with this unique data set to really rigorously characterize the use of GLP-1s, not among people undergoing surgery. In fact, we required that people not have any evidence of GLP-1 use prior to surgery. And what we focused on was rigorously characterizing the initiation of GLP-1s after bariatric surgery.
Now let's dig into this data set a little bit. You followed over 112,000 patients for a minimum of 2 years after their surgery to investigate the initiation of GLP-1s. Can you please summarize your main findings for us? And please tell us if you had any surprises in those findings.
So I guess one of the major findings was that 14% of patients, which means 1 in 7 individual initiated GLP-1 anytime after surgery, and 1 out of 10 patients, which is around 10% of patients, initiated GLP-1 within 5 years after bariatric surgery.
Another really interesting finding, and to be clear, we went into the study wanting to examine this, was whether or not GLP-1 initiation was related to either the weight prior to undergoing bariatric surgery or the amount of weight loss achieved after surgery. And the answer was yes. But we felt that it was really important to characterize these associations, that is, the degree to which people were being initiated on GLP-1s because of what patients and clinicians may have judged to be insufficient weight loss after surgery. And to be clear, this is a moving target. As we can discuss, the GLP-1, the use and recommendations about GLP-1 use in this and many other settings are moving at the speed of light. And so we expect accumulating evidence over the next few years that will further help to inform when patients and bariatric surgeons and other obesity physicians should pull the trigger and should initiate patients on GLP-1 therapy.
And I'm glad you brought that up. You have a great infographic in the paper that really shows the explosion of the use of GLP-1s really starting after about 2020. Do you expect those numbers to continue to increase?
Yeah, we certainly expect that number will grow significantly in coming years. especially with the introduction of these newer agents or the approval of these newer drugs for obesity, semaglutide and tirzepatide.
Yeah, I think those are great points, Emil, and I concur. I think to be clear, you don't have to go far or read far to see barriers in people's efforts to access these medicines as well. And this also is a moving target. But of course, there are many patients face prior authorization or step therapy as part of insurers' efforts to constrain costs associated with these products. And as the products get older, we will both, I think, face fewer managed care barriers to their use in varied settings, but also I expect a growing evidence base. And as other papers contribute additional evidence and perspective on the optimal role of GLP-1s in this type of setting, I expect it to be increasingly commonplace that patients will be initiated on GLP-1s after bariatric surgery.
I'm glad you brought that up. And, looking at your regression model, who was more likely to get prescribed?
Yeah, so one obvious finding was that individuals with greater BMI at baseline were more likely to initiate GLP-1. Also, individuals who did not lose more weight or regain more weight after bariatric surgery were more likely to initiate GLP-1. We also noted that individuals undergoing sleeve gastrectomy, a type of bariatric surgery, were more likely to initiate GLP-1 compared to people undergoing RYGB, Roux-en-Y, and gastric bypass. And of course, patients with certain comorbidities like diabetes, sleep apnea, and dyslipidemia, they were also more likely to initiate GLP-1.
I also thought what was interesting was the timeline of the initiation after surgery, and that 14% were initiated right after, but really the greatest percentage was initiated during year 3. Do you have an idea why that might be?
Yeah, I mean, it's a great insight. And we were a bit surprised by it as well. I would have expected going in, blinded to the results that initiation would occur earlier more often and that we wouldn't see such a broad distribution of people initiating, 2 years, 3 years, even in 4 or 5, 6 years after surgery. So I think we can only speculate. Our work wasn't really designed first and foremost to fully characterize the reasons for initiation, but one can speculate that individuals may be regaining weight and reaching a certain threshold where patients and clinicians make the decision to initiate. Of course, there are other things going on here too, right? Like we know that many of these patients have diabetes, and GLP-1s are, of course, indicated for diabetes. So I don't think we can fully know from our work alone why the initiation was, in some sense, staggered over such a long period after surgery.
And to flip it now for our listeners who may be patients, if I am a patient and I've undergone weight loss or bariatric surgery, when should I ask my physician about potentially starting a GLP-1?
Yeah, well, it's a great question. I'm a practicing general internist, and I don't have an obese patient where we haven't had some conversation, at least obliquely, about these products. And so, I think patients should feel empowered to discuss with their physicians early and often the potential value of GLP-1s and other pharmacologic and, yes, non pharmacologic approaches to managing weight. So I don't think that there's a specific point in time where this discussion has to occur, but I think patients and clinicians have to navigate these waters together. And I think most patients going into bariatric surgery have already learned something about the varied approaches and management options that there are to manage obesity. With that being said, I would remind you our study excluded people that had had a GLP-1 within 12 months of surgery. So these are not people that tried a GLP-1 and failed a GLP-1 and then moved on to surgery.
But I think it also is reassuring for patients that have undergone bariatric surgery in the past. Maybe they're 3 years out, 4 years out, 5 years out. Whereas before GLP-1s, from a surgeon's perspective, our alternative was more surgery. And so I think it is reassuring that patients have other options. And that, in other words, it sounds like to me, there's never a too late.
Yeah, I mean, listen, I'm a pharmacoepidemiologist, and we always remind people it's not about risks or benefits, it's about risks and benefits. With that being said, GLP-1s are real game changers. To be clear, the weight loss that we see using observational or real world data, and I'm talking about other studies that we and others have performed, it's always more modest than what we see in the clinical trials. It's never that good. But with that being said, these products really are game changers. And I think they should serve as a reminder to patients and clinicians alike that there are many tools in the toolbox. And yes, we are still prescribing other treatments, other pharmacologic treatments for obesity as well, but they don't have the efficacy and the overall risk benefit balance that I think makes GLP-1s the right choice for for millions of Americans, frankly.
And so, on the other side of the equation, as a surgeon, if I'm a bariatric surgeon, what should my practice be? Which of my patients need it? When do I start it? Or do we even know the answer to that yet?
So these are great questions. Our study didn't really address these questions, but it raises an important point that nearly 1 out of 7 patients uses GLP-1 after bariatric surgery. And of course, we need more evidence about safety and effectiveness of these drugs after surgery. And these are great questions like when do we start? How long do we start? If we start, when do we stop? Who are the right people to initiate GLP-1 after bariatric surgery? And we are working on some of these questions in future research.
Yeah, I think the guidelines will continue to evolve and people will be looking at them quite closely. And I think it's these sorts of settings that are really laden with uncertainty where guidelines can be so valuable. And we hope that our analysis and others that we and other teams are performing can contribute a small part to helping to shape these guidelines and improve clinical care.
Well, Dr. Mehta and Dr. Alexander, thank you both so much for joining me today to discuss your important paper, which our listeners definitely need to check out. For our listeners, you can find a link directly to the article in our show notes. This episode was produced by Daniel Morrow at the JAMA Network. To make sure you don't miss an episode, click subscribe to follow this and other JAMA Network podcasts. You can also visit us online at jamanetworkaudio.com or search for JAMA Network wherever you listen to your podcast. Thanks for listening and have a great day, everyone.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.